Our first speaker, we'll just get right going with Dr. Laura Tarter. She'll be talking to us today about SLE and the Antiphospholipid Syndrome. Dr. Tarter, thank you for joining us today.
Great, thank you, and good afternoon, everyone. So our first topic today will be SLE and the Antiphospholipid Syndrome. So we're going to start with an overview, just briefly, of what is lupus, talk a bit about classification criteria for how we decide if a patient may or may not actually have lupus, and then we'll focus on clinical cases to go through clinical manifestations of this very heterogeneous disease, and then talk about principles of treatment, and then we'll talk about the antiphospholipid syndrome. So briefly, let's talk a bit about what is lupus. Lupus is a prototypical autoimmune disease. We know that genes play a role, and certain genes confer increased risk of developing lupus, particularly complement variants, as well as certain HLA variants. We know environment plays a role, particularly UV light, gender, infections, and other parts of the environment as well. And we know that this leads to an abnormal immune response, with particularly a failure of regulatory mechanisms that should sustain self-tolerance. This in turn causes autoantibody production and immune complex formation, which then can lead to inflammation, causing the classic signs of lupus, things like rash, nephritis, arthritis, and other manifestations. And then over time, this can lead to damage. So in terms of epidemiology, the prevalence of lupus is about 1 in 1,000 in the US. It's diagnosed 9 times more in women than men. And in the US, it's more common and more severe in women of African, Hispanic, or Asian descent. We know there is a genetic predisposition, as we discussed, and there are greater than 30 gene polymorphisms that have been linked to lupus. And then possible contributors to those genetically predisposed include sex chromosome genes, sex hormones, environmental influences, including UV light exposure and smoking. So lupus is often called the great imitator because it can look like so many different diseases and because it can affect so many different organ systems. We know that people with lupus very frequently have constitutional symptoms. 80 to 100% of patients develop these symptoms, including things like fatigue, fever, and myalgia. And then musculoskeletal symptoms, arthralgias and arthritis, are also very common, as are mucocutaneous symptoms, including rashes and oral ulcers. And then finally, renal involvement. So kidney involvement occurs in about 50 to 60% of patients with lupus, and is something we have to be very vigilant to look for frequently in patients with lupus. So let's talk a bit about classification criteria. There are several different classification criteria systems. The most sensitive and specific is the SLE classification criteria for lupus. And you will see these different systems. And the basic idea is that there is not one test that tells you if somebody has lupus or not. With the SLE classification criteria, a patient needs to fulfill 4 of these criteria. At least 1 needs to be an immunologic criteria, ideally a positive ANA, and at least 1 needs to be a clinical criteria. And you see in the clinical criteria, these include things like rashes, so acute or chronic cutaneous lupus, oral or nasal ulcers, non-scarring alopecia, arthritis, serositis, renal involvement, neurologic involvement, hemolytic anemia, leukopenia, and thrombocytopenia. And immunologic criteria includes the ANA, so the anti-nuclear antibody test, which we'll talk a little bit more about. And then also what's called a group of tests called subserologies. So these are other specific anti-nuclear antibody tests that are more specific for lupus. This includes anti-double-stranded DNA, anti-Smith, and then antiphospholipid antibodies, low complements, and a direct Coombs test in the absence of hemolytic anemia. So a few notes about the ANA test. The ANA test was not designed as a screening test. Up to 20% of healthy adults, particularly women, have a low titer positive ANA and do not go on to develop rheumatic diseases. And up to 5% of healthy adults actually may have high titer positive ANAs and still don't develop rheumatic diseases. Causes of false positive tests include chronic infections like HIV, Hep B, Hep C, SBE, a family history of rheumatic disease. Studies have shown that up to 50% of first-degree relatives of people with lupus may have a positive ANA, and the majority of these people do not develop lupus. Other autoimmune disease like GI or thyroid disease, and then normal healthy people. And the other thing to keep in mind about the ANA test is once a patient has a positive ANA, it does not need to be retested unless symptoms change and there is an increased suspicion for a rheumatic disease. So let's talk now about cases, as this is a good way to go through the clinical manifestations of lupus. So this is our first case. This is a 33-year-old woman. She has mouth sores and a rash over the bridge of her nose that looks like this. And so just to sort of describe this rash, this is a classic malar rash with erythema over the malar eminences, as you can see there. And there's slight scale, and very importantly, it spares the nasolabial fold. So if you look closely, this rash does not cross her nasolabial folds, which is key to the diagnosis of a malar rash. The differential diagnosis is to also consider is things like rosacea or flushing or mitral stenosis. However, all of these things can theoretically cross the nasolabial folds. So you send an ANA and it returns positive at a titer of 1 to 320, and you send subserologies and the double-stranded DNA is positive. So now, does she have lupus? Let's think about our criteria. She has acute cutaneous lupus in the form of a malar rash. She has oral ulcers, an ANA, and a double-stranded DNA. So she has 4 criteria. So she does have lupus. This is mild lupus, but this is an example of mild lupus. So skin manifestations of lupus, we're not going to go through this in great detail, but what we just saw was an example of a malar rash, which is an example of acute cutaneous lupus. There's also subacute cutaneous lupus. This is associated with SSA and SSB antibodies. This is a classic presentation of subacute cutaneous lupus. And then chronic cutaneous lupus, you see over here in the third image, the classic manifestation of chronic cutaneous lupus is discoid lupus, and this is an example of a discoid lupus lesion. These lesions scar, and they usually have an erythematous border. And then lupus can also have non-specific lesions like alopecia, Raynaud's, and vasculitis. And these are called non-specific because they also happen in other disorders. So case 2, this is a 32-year-old woman who develops about a month of joint swelling in the small joints of her hands, so MCPs and PIPs. Her labs are notable for leukopenia, a positive ANA, and a positive double-stranded DNA. So let's think about, could this person have lupus? She has arthritis, leukopenia, ANA, double-stranded DNA. You don't find an alternate explanation. So yes, this is a case of lupus. Now, this here is an example of a classic finding in lupus arthritis, which is Jacobs-like arthropathy. So what Jacobs-like arthropathy means is that somebody may have, deformities in their fingers that look like rheumatoid arthritis, but they are reducible. As opposed to rheumatoid arthritis, where the deformities are classically not reducible. So musculoskeletal manifestations of lupus are very common. We see this in more than 90% of patients, include arthralgias and arthritis. Septic arthritis can occur, osteonecrosis, myositis, and myopathy. So case 3, this is a 29-year-old woman with a history of mild lupus with arthritis, malar rash, serologies, who's now coming in with edema, proteinuria, and red cells in her urine. What do you do? And the answer here is you think about lupus nephritis and you do a kidney biopsy, and you should suspect lupus nephritis if a patient develops microscopic hematuria, has red blood cell cast or dysmorphic red cells, and has proteinuria of more than 0.5 grams per day, which can be approximated in a spot protein to creatinine ratio. And I'm sorry, this should have a title here, but somehow it doesn't. And so the point of this is to sort of say that in addition to these things we've been through, like musculoskeletal, mucocutaneous, and renal manifestations of lupus, lupus can affect multiple other organ systems. And I'm just going to kind of go through these other manifestations quickly in the interest of time. So hematologic manifestations include autoimmune hemolytic anemia, so Coombs positive hemolytic anemia, leukopenia, which is common, particularly with a white cell count of less than 4,000, and lymphopenia is the most common development in terms of leukopenia. And the lymphopenia develops when the lymphocyte count is less than 1,500, and then thrombocytopenia. Cardiovascular manifestations of lupus are something we look for very carefully. In particular, accelerated atherosclerosis, which is probably due to both inflammation from lupus itself and also from the medications used to treat lupus. The relative risk of cardiovascular disease in lupus is at least 2 times higher than the general population, but there's a dramatically higher relative risk, not absolute risk, but relative risk in younger patients. One study suggested a 55-fold higher higher risk in women in their 30s with lupus of developing cardiovascular disease versus age-matched controls. So this is something that really needs to be considered and looked for carefully in these patients. Pericarditis is another consideration, as well as valvular heart disease, usually with positive antiphospholipid antibodies. This is called Liebman-Sachs endocarditis. Coronary vasculitis can occur, but is rare, and myocarditis also can occur. Pulmonary manifestations of lupus include pleuritis, lupus pneumonitis, chronic interstitial lung disease, pulmonary hemorrhage, which has a high mortality, and shrinking lung syndrome, secondary to diaphragmatic paralysis and lung disease. And neuropsychiatric manifestations of lupus are another important consideration. Neurologic manifestations there are many different neurologic manifestations, including strokes, seizures, transverse myelitis, optic neuritis, meningitis, headaches, neuropathies, and many of these are associated with antiphospholipid antibodies, but not all. And then psychiatric manifestations of lupus are also quite well described and include psychosis, cognitive disorder, pseudodementia, and functional disorders as well. The GI tract can also be affected by lupus and can cause abdominal pain, anorexia, peritonitis, pancreatitis, and hepatitis. And then other common symptoms include particularly fatigue, headaches, malaise, and cognitive impairment, also called lupus fog, and myalgias. So case 5, 63-year-old man started on procainamide for an abnormal heart rhythm. He develops joint pain and a skin rash. Workup reveals a high titer positive ANA and antihistone antibodies. So this is a classic example of drug-induced lupus. Patients present with lupus-like illness. They usually have arthritis, rash, and serositis. It's rare to have renal, neuropsychiatric, or vasculitic disease. Positive ANA and positive antihistone antibody is uniformly found, or nearly uniformly. And this often responds to drug withdrawal, NSAIDs, or low-dose prednisone. Culprit agents in drug-induced lupus to think about, the common ones are procainamide and hydralazine, and then there's a long list of rare drugs that can also rarely be associated. So now let's talk a little bit about the treatment of lupus. The general treatment advice for all patients with lupus includes sun avoidance and protection, because UV light can trigger autoimmunity in the skin and can trigger lupus. Diet, exercise, and smoking cessation. And then in terms of treatment for mild disease, so this is things like symptoms of low-grade fevers, rash, arthralgias, and fatigue. The key is antimalarials, and these are key for all patients with lupus. Hydroxychloroquine is the most common, and all patients should be on antimalarials unless contraindicated. They have been shown in randomized trials to decrease the frequency and severity of flares of lupus. There is potentially a mortality benefit, and there's symptomatic benefit with constitutional, musculoskeletal, and cutaneous manifestations, in particular being controlled with antimalarials. Low-dose prednisone is also a consideration, less than 10 milligrams a day, with tapering as fast as possible, and NSAIDs. And about 80% of patients with mild disease achieve good control with these measures. For moderate to severe disease, we start to think about other agents, including higher doses of steroids, particularly for renal or CNS involvement, cyclophosphamide, which has several different dosing regimens, again, for renal or CNS involvement, azathioprine, mycophenolate mofetil. Both of these are used for renal disease, hematologic and skin disease as well, tacrolimus, methotrexate, and then belimumab, particularly for steroid-resistant serositis and arthritis, and rituximab and abatacept are used off-label as well. So summary of lupus. Lupus is a multi-system autoimmune disorder. Lupus can look like many different disease entities. To diagnose lupus, the ANA should be positive, but a positive ANA does not make a diagnosis of lupus. Direct treatment should be directed towards the underlying system involved. And all patients, unless contraindicated, should be offered hydroxychloroquine. Steroids and other immunosuppressives are also commonly used. And then biologics other than belimumab are under investigation. So now let's move on to a discussion of the antiphospholipid syndrome. So when do you think about the antiphospholipid syndrome or antiphospholipid antibodies? You start to think about this as well in patients with multiple early miscarriages, thrombocytopenia, unexplained thrombocytopenia, stroke or TIAs in younger patients, DVT-PE. This should be part of a workup for DVT-PE, and then patients with lupus. About 30% of patients with lupus have positive antiphospholipid antibodies, and 30 to 50% 50% of that subset of patients may actually develop antiphospholipid syndrome. So antiphospholipid syndrome, remember, is different from just being antibody positive in that to have the syndrome, a patient needs to have antibodies, but then also have clinical criteria. And so clinical criteria are an arterial thrombotic event, a venous thrombotic event, or recurrent pregnancy losses of 3 or more consecutive losses at less than 10 weeks, 1 or more unexplained deaths of a morphologically normal fetus at greater than or equal to 10 weeks, or 1 or more premature births before 34 weeks because of placental insufficiency or preeclampsia, plus laboratory criteria. And so laboratory criteria include anticardiolipin antibodies, IgG or IgM, at moderate to high titers, or beta-2 glycoprotein 1, IgG or IgM, antibodies at moderate to high titers, or lupus anticoagulant test being positive. And these laboratory criteria have to be positive on 2 separate occasions, 12 weeks apart, as sometimes in the setting of acute clots in particular, particularly anticardiolipin IgM and beta-2 glycoprotein 1 IgM can be transiently positive. And there also can be associations of these labs being positive in the setting of inflammation. So that is why the tests need to be positive 12 weeks apart to really confirm that somebody has antiphospholipid syndrome. So there are also non-criteria manifestations. So these are manifestations of antiphospholipid syndrome that are not part of the criteria for diagnosis, but are common. And these include thrombocytopenia, Coombs positive hemolytic anemia, livedo reticularis, which you see an image of this over at the upper right-hand side, Raynaud's phenomenon, and here's an image of this on the lower right-hand side, migraines and cognitive dysfunction, valvular vegetations or thickening, so this is Liebman-Sachs endocarditis, or renal disease, including particularly thrombotic microangiopathy. So medical conditions that can be associated and are described as associated with antiphospholipid syndrome include Sneddon syndrome, which is strokes and livedo reticularis in young women, Evans syndrome, which is immune-mediated thrombocytopenia and Coombs positive hemolytic anemia occurring together, CVAs and MIs in individuals under age 40, lupus, and then catastrophic antiphospholipid syndrome, which we're going to talk more about. This is sudden multisystem occlusive disease. So the treatment of vascular APS, so vascular antiphospholipid syndrome, is lifelong anticoagulation, generally with warfarin. And then the optimal INR goal for venous events is 2.5, so regular 2 to 3 kind of range. Arterial is at least 3, and recurrent is typically 3.5. Now, very importantly, direct-acting oral anticoagulants should absolutely be avoided in the treatment of antiphospholipid syndrome. Rivaroxaban for APS was studied in 2 different trials that were stopped early due to a higher rate of thrombosis in the rivaroxaban arm. So there is an apixaban trial ongoing, but based on what we know at this point, given the higher rate of thrombosis and in particular of strokes in the rivaroxaban arms of the trials that have been done, it would not be advisable or safe to use direct-acting oral anticoagulants at this time for antiphospholipid syndrome. So the other question that always comes up is the treatment of antibodies in the absence of clinical events. So thrombosis, patients with antiphospholipid antibodies can have a thrombosis risk of up to 4% in terms of annual risk. So some have advocated the use of prophylactic low-dose aspirin, but the effectiveness of this is not supported by RCT data. There was one randomized control trial that was done that attempted to answer this question, but was underpowered. However, data do suggest that aspirin may be protective in patients with lupus with antiphospholipid antibodies. So my clinical practice is to offer aspirin to all patients with lupus who have antiphospholipid antibodies. So then let's talk a little bit about catastrophic antiphospholipid syndrome. This should be considered when multiple clots happen over the course of a week or a shorter period of time, including manifestations can be things like renal failure, diffuse alveolar hemorrhage, adrenal hemorrhage, encephalopathy, so really severe manifestations. And this can look similar to other thrombotic microangiopathies. The treatment for catastrophic APS is really, there's nothing supported by trial data, but anticoagulants are essential, as well as high-dose steroids have been used, and we're typically used for this IVIG, plasma exchange, eculizumab, so inhibition of C5, and rituximab, so inhibition of CD19. or CD20 rather, sorry. So summary of antiphospholipid syndrome. So antiphospholipid syndrome is defined as arterial clots, venous clots, or obstetrical complications in the presence of an antiphospholipid antibody. The antibody test needs to be positive on 2 separate occasions at least 12 weeks apart. And the treatment for vascular thrombosis is lifelong anticoagulation and not with direct acting oral anticoagulants. So let's see. So now we're going to start our question. So question 1, a 23-year-old woman presents with malaise, achiness, and intermittent facial rash that does not spare the nasolabial folds. So it crosses the nasolabial folds. Appropriate workup includes A, ANA, B, CBC with differential LFTs, creatinine urinalysis, or C, double-stranded DNA. Okay, keep going now. Okay, so the answer is B, CBC with differential LFTs, creatinine, and urinalysis. So as a first pass for the evaluation of suspected SLE, a complete history and physical exam should be performed. Appropriate laboratory testing includes a CBC and differential, liver function test, creatinine, and urinalysis. Avoid sending an ANA and or double-stranded DNA unless there is a strong suspicion for SLE. And in this case, this is somebody with malaise and a rash, but the rash crosses the nasolabial fold, so there is not a strong suspicion for SLE. Okay. So question 2, a 43-year-old woman presents with a DVT with no clear precipitant. Past medical history is notable for 2 first trimester miscarriages and 1 second trimester miscarriage. Appropriate testing includes A, lupus anticoagulant, B, anticardiolipin, IgG and IgM, C, anti-beta 2 glycoprotein 1, IgG and IgM, D, rapid plasma reagent, RPR, E is A, B, C, and D, and F is A, B, and C only. Little bit of a sort of letter salad there, but okay. And it looks like people mainly got this. So the answer is F, A, B, and C only. So her history is certainly suggestive of possible antiphospholipid syndrome. All 3 types of antiphospholipid antibodies should be sent when you have a high suspicion for antiphospholipid syndrome and should be sent again as confirmation after 12 weeks. RPR is not a good screening assay for this disorder. There can be false positives in the setting of lupus anticoagulant, but it's not a good screening test. And these are references for further reading. And that's it. Thank you.
Laura, thank you very much. I think we have time for one question. Laura, there was one question about if a lupus patient who is APL positive, and I'm not sure what the questioner's question was with regard to if they'd already had a clot, but if they were positive in lupus and were APL positive, what approach would you take with anticoagulation or consideration for anticoagulation in the pregnant lupus patient in that situation?
In a pregnant lupus patient?
Yeah, so if they've been deemed APL positive in the past, and I think for the sake of questioning that had been tested but were not themselves, had not had actual APL syndrome or APS in the past, no clots or anything like that,
But they
how would you handle a situation like that?
In pregnancy. So, just going into pregnancy with positive antiphospholipid antibodies is not an indication for anticoagulation. The indication for anticoagulation is having actual obstetrical APS, which is by definition is having had 3 early miscarriages or 1 second trimester miscarriage or 1 early fetal demise or preterm birth because of placental insufficiency or preeclampsia. So you would not anticoagulate automatically in a patient with lupus who has antiphospholipid antibodies and is pregnant, assuming they had never had a clot in the past. I would definitely give that person aspirin as prophylaxis for preeclampsia, and also Plaquenil, which also serves as at least somewhat of an anticoagulant.
Excellent. I think we'll probably stop there. And we do have a few other questions, which we'll save for the end. Dr. Tarter, thank you so much for your talk today. Excellent. Thank you so much.
Thank you.